relationship paragraph and welcome to our Levitt lectureship. Louis Levitt was born in 1896 and attended the medical school at the University of Colorado, from which he graduated in 1927. Practiced for 40 years in Denver as a general practitioner until 1967. When he died in 1978, he left an endowment to the Department of Family Medicine, which we have used as the Levitt Distinguished Lectureship. By now, we've invited over 60 distinguished speakers, consultants, and guests to the Department of Family Medicine at the University of Colorado. Perhaps the most distinguished among them is with us today. It's my privilege to introduce you to, you can see, Dr. Rafael Bengoa, who comes to us more or less from the Deusto Business School, where he's the head of the Department of Health Policy and Leadership and Policy, which is a very interesting arrangement at a Jesuit university in Spain. Dr. Bengoa is, he is an academician. He's been a practicing clinician. He is a physician, but most of his professional life has been organized around policy work. He's worked for the World Health Organization, where he sort of headed up their chronic disease management and then looking at health policy initiatives around the world. He has been a Minister of Health for the Basque country in Spain, and he's been a consultant for many, if not most, of the nations in Europe with respect to their health policy initiatives. He's currently working in Cambridge. He's been in the U.S. He's working here for 3 months at Harvard. He has an appointment at McGill University, and somehow we were fortunate enough to secure this engagement. And we've just been beating him to death. We've been working him to death for the last 2 days, where he goes from one talk to another. He's still smiling, and he's still on his feet, and he still says, "I'm okay," so he must be used to this. I figure a health minister can take anything. Today, he's going to talk with us about something that's incredibly important to us. He's been working essentially in national health systems that are changing, that are trying to transform, and that in fact are transforming in ways that we only wish we could. He knows something about how to transform a healthcare system, and he's going to talk to us today about transforming healthcare and approach to system-wide implementation. Dr. Bengoa.
Okay, thank you very much. Thank you very much, Dr. Decree, for having me here. It's a pleasure to talk to all of you. I think I'll be speaking for 35, 40 minutes, so you can eat slowly and patiently, and then we can open it up for questions. The idea of using the word, as Frank was saying, system-wide implementation, is because, as you know, in Europe, we're now beyond the coverage issue that is so, of course, present in the American system right now. But we still need system-wide transformation. You'll see from the things I say that at the change at the delivery level, which you also have to engage with, hasn't happened in Europe. So we may have been successful at creating, let's say, universal health coverage in most of Europe, in both insurance systems in the Central Europe or NHS type of systems in the north and the south of Europe. But we haven't really been successful, like I think anybody else has, at transforming the delivery of healthcare towards with what we need. In the last 3-4 years, things have been happening in that area, in the delivery reform. And that is what I think Frank and his colleagues were asking me to bring over, to try to relate it a bit to the things that I think are happening in the U.S., and then decide, a bit what may be happening next, both in Europe and here in the U.S. I'm not going to go into all these challenges. You all know that, let's say, all these pressures, even each one of them, where we're talking about doing better job in prevention and demography and handling better disability and long-term conditions, the rising expectations from the citizens, the quality agenda, the patient safety agenda, all those agendas are absolutely huge. And when you're the Minister of Health, you actually don't know where exactly to start with all that, because it's all coming down on you at that moment. And you have to do something, not only with one of those, but with all of those. Let me just say that you can pretend you're doing something about them for years and not do something about them. You can play at the policy level with this stuff, use the words, and actually not do anything except cost containment, which is maybe happening in many places in Europe. We decided as a group, and I had a fantastic group working with me, that we did not only want to be the cost containment gang in the next 4 years, and that we wanted to actually launch simultaneously a more transformative agenda to do something about most of these things. Not sure if we have, but basically that was the big intention behind. So you're actually saying to yourself as a policy leader, I'm not in charge of a system, and it is my job, it is my responsibility, my duty to engage with this and not just play around with it. As you know, both here in the U.S., this is what's happened, of course, in life expectancy, both in the U.S. and in the comparisons with 5 EU countries. But basically, we've all gone through the same increase in global life expectancy. As you know, that is fantastic, but it has come with some headaches. It has come with this picture in relation to chronic diseases. As you know, about 1/3 of our population has between 1, 2, 3, 4, 5, up to 7 and 8 chronic conditions. I think many of you as physicians see these complex patients. They're a consequence of many, many things, of course, in terms of their individual life, but it's also a consequence of bad public health that we've all been doing. It's also a consequence of that demographic shift. And again, one can say, well, I'm going to survive. I'm on a political career, which was not my case, but if you are, I better not get into all this stuff because I'm going to lose as an individual on this. And that, I think, obviously is happening to some people because the agenda seems too big, seems too broad, seems too ambitious to take on. What's really interesting is that some people, and led very much, as you'll see later, by a lot of frameworks which have arisen in the U.S., in Europe, we've used those frameworks, and I like to say that we're using them better than you are. They're your frameworks, but we're using them better than you are. You have to find out why after. But that is actually, I think this is happening. You know, sometimes you have something in front, you have the solution just in front of you, but somebody else who sees it from far away with perspective starts using it, you know, and we have, and they've been very useful to deal with that. That demography, that let's say that extent of chronic conditions, and I won't stay too long on building up the case and the arguments for why we need to change, but even if you just take a very clinical side to it, and you forget the long-term consequences of all that, they're even getting a bad deal, chronic patients, under the area of patient safety. You can see that people the percent of reporting wrong medicine and wrong dose of people with, this is across the Commonwealth, with 2 or more chronic conditions versus the people with 0 or 1 chronic condition. You just, as soon as you start having these conditions at the clinical level, you start getting a better deal. So not only have you had a bad deal, not only have you had a bad deal before as you were building up this disease and you were not on the radar of the system, and most of our systems were not really helping you to engage and to self-manage correctly and to help you manage these conditions, but also when you're within the clinical system, you're also more in trouble than other people, as you can see. Now, of course, as we know, the consequences of the things I've just said, it's because we still have a very fragmented system. I think we all know we give pretty good clinical care, I think both in Europe and most places in the US, in most places in the world. We give good clinical care in each of the institutions, when you're in a hospital, when you're primary care, you're in an ambulance. But the whole thing breaks down when you start talking about continuity of care and when you start saying, well, most of these patients actually need something which is called continuity of care, need something which is much more an integrated pathway. And I think neither Europe or the US or other countries are offering that integration for the moment, except obviously in very specific places, both in the US and Europe, who are doing a much better job at all this. But in general, we're not there. So because of those challenges and because of this fragmentation and because we're on an acute agenda and because of the excesses of a fee-for-service arrangement here and in some European countries like Switzerland, what happens is that you're fragmenting the system from above. So it's not clinicians which are fragmenting. It's actually the system, the people that have system responsibility at the policy level who continue the fragmentation in one way or another because they continue financing fragmentation. So if you're financing fragmentation, that's what you get. And of course, the loser there hasn't been in many places doctors or nurses or health professionals in general. It's been the patient. Now, this is what happens in the Basque country. I think it's typical. But today, this is a picture that we just went in. It's called Leading System Networks. It's by McKinsey. They did a really interesting sort of international study. The same thing happens everywhere in the world. But let me just tell you, this is what I'm doing, or what I was doing 2 years ago, 3 years ago in the Basque country. If you take the whole top, which is basically what can you do on primary prevention, on early management of cardiovascular disease, on acute management of myocardial infarction, rehabilitation, secondary and tertiary prevention, what happens there across that spectrum? This is what we're doing. So we went and asked, what is that you're doing in public health? What is it that you're doing in early detection? What is your group doing when you're in the hospital? What is it you're doing after rehabilitation? And what we did is just put the picture together. And when you put the picture together, you see where you're failing. And of course, we all know where we're failing. I'm okay on the greens and yellows, more or less. That's the downstream stuff, health services, the acute stuff. But I'm doing poorly in the early management of that condition and poorly as well on some of the preventive upstream issues around smoking, etc. The interesting thing about putting this together is that when you look at it and you offer it to clinicians, they say, well, we have to do something about it. Even if they're the high-tech clinician putting stents in one part of the picture, they say, well, we better start doing something about this. And it's very interesting that by just combining the picture and taking the picture, you have a little tool to start engaging people in a broader picture than the one you have when you're just in your little tidy silo in which we work. Now, this is a national scorecard, not only the US, but others. And just to finish that context, you can see here in terms of preventable deaths, you know what you're spending here, about 18% of your GDP on health. And the scorecard, when you compare it with other countries, is not looking good. And that's why, of course, the present administration is doing what it's doing. because the scorecard is not looking good. You can see that if you were to be doing things like some of the system arrangements in other places, you could see that there would be, in this case, preventable 80 to 84,000 fewer people would die prematurely. You can see the wastage that there is in your system in health insurance waste on the second one there, that figure 7, because you use about 1/4 of your dollar in just administrating the insurance schemes. You can see that if you were, the third one, the better care one, you can see that if you were to do everywhere in the U.S. as good as the people who are doing really good in the U.S., you would be doing, having a much better preventive and screening system than you have. And then the Medicare savings that you're calculating are absolutely spectacular. We'll see another one of that if we were to do things a bit different. I'm not showing this just to say the outcomes in the U.S. are worse than elsewhere, because or that you're spending more. In Europe, we have been doing some of this, and our outcomes are slightly better because we have universal health coverage. That's one of the reasons why that is that. It's not because we're doing better clinical work or we're doing better public health, because as I told you, we haven't cracked the next phase, the delivery change, either. So the idea to get universal health coverage, of course, is absolutely fundamental, because then you can get on to the real stuff, which is much more complicated, which is how to change delivery and how to start integrating what needs to be integrated. Both in Europe and in the US, this is how those costs are concentrated. You can see that, you know, a very small part of the population is using a large amount of, these are those patients that have pluripathologies, that have several things going on. They're taking many drugs. They're very complex patients. They come in through emergency department several times a year. And you can see that in other sectors, when they take this picture, whether it's airline or banking or insurance schemes, they manage these groups in a different way. In healthcare, we haven't pulled that off everywhere yet. Some parts of the US are doing fantastic work on that. And that's one thing in Europe we're copying. We're copying the people who are doing it well in the States. And this concept of 20% of the patients using 80% of the funds is something we've stolen from you, and we've confirmed it's the same thing in Europe, and we're doing something about it, as some organizations are doing in the US. This is the care savings if we were to be able, both us and Europe, to be able to do things differently. And a lot of people say, well, okay, well, how is this going to be efficient? How's the new law here? Or how the new schemes and laws in Europe really going to be efficient if we organize chronic diseases in a different way, if we organize a better preventive setup? This is the type of savings, and this, in the case in the US, it's $306 billion if we were to do things differently. So this is your calculation on your system, saying if we were to be able to manage a different delivery system in the way that the people that I put up before need, we would be saving this amount. So a lot of people say, okay, well, how is all this stuff going to be efficient? Well, it's going to be efficient if you do a different delivery arrangement. So what we do know, and I think we all can coincide, is we can't treat our way through this. With the acute system, the system that we have is not going to be able to pull off those savings. It's not going to be able to pull off better results because we've been trying that for a very long time in Europe and elsewhere. And obviously, we obviously then need to be doing things in a different way. Now, the good news after all that bad news is that 10 or 15 years ago, we weren't sure what to do with all this demographic challenge and quality challenge, and chronic diseases were already coming up, etc. But now we do. Now we're beginning to know what to do. Some people are not doing what we know what to do. It's as if we were doing something in medicine that we know is good for a patient, but we're not doing it for the big patient, the system. New legislation, the one you have, which carries things around coverage and carries things around delivery system, basically contains, at least that's my perspective, what we all need. We need to be building, we don't call them ACOs or integrated local organizations of any time, but we all trying to build some sort of local community organization where we can do a better job in population health terms. The European strategies, the European legislation are also trying to go in that direction. In Europe, of course, it's mainly just delivery reconfiguration. We've done the coverage stuff. But we're not getting the results that those people need. We're also on an acute care agenda. So just because you've done coverage or you're in more control of the system because you have an NHS type of system, it does not mean you're offering integrated care. So in Europe, we have not been successful at doing population health, integrated care, etc., just because we have a nice and tidy integrated, in theory, system with a single payer. Single payer is a really good idea, but we have not used it well. So we're not going to get rid of single payer, but we're going to start using it really well, which means using financing from above in a different way, towards more global payment arrangements, more bundled payment arrangements, etc., on providers, etc. Very different systems in Europe are going in this direction. So different systems means Netherlands is the country that looks most like you because they basically have a competitive system at work. They believe in market forces. They're encouraging market forces. In the rest of Europe, except in Switzerland, that's not at work. We have more of a, let's call it a planned system, an NHS type of system, and other insurance systems like France or Germany are fairly planned in many ways. Now what's important is that although there's very different, and although some people are in a market logic and some people are in a planned logic, we're all going in the same direction towards these local configurations of being able to manage more integrated care and more population health. And let me just say also something which, sometimes is curious, but both the right and the left, politically, in Europe, are doing this. The right in Europe is comfortable with doing this. The right in Europe keeps single-payer systems. The right in Europe thinks that you can make these delivery changes with the existing model we have without, going into introducing new market forces except the countries I mentioned before. So actually, one does not necessarily have to look to the left in Europe. One can see that the right is trying to improve these systems as well. And that's why there's so many common denominators among very different systems. You're doing the coverage expansion and at the same time the health delivery reform. We've done the first and we need to do the second. The message for me when I'm trying to work across the Atlantic a bit in different ways is why don't we do that together, the second one? Why don't we do that together so we can learn together as we move forward? What happens to you at the policy level then is you have to take a big decision about two agendas. You have low-hanging fruit, which is the stuff on the left over there, which is about making much more generic prescription versus brand prescription, about playing around with salaries, maybe disinvesting in some technologies that don't add clinical value, etc. The sad thing about that is that even if you do a really good management job out of that, it doesn't change anything. Even if you're a really good manager and you control costs there, and that's your policy, which is happening in many European countries, that hasn't changed anything. You've just pleased your Minister of Finance, which is really pleased with this stuff. So what 6 or 7 countries are doing is, okay, I'm going to do that stuff. But where my personal capital or my team is really going to be going is I'm pushing a new delivery transformation. That means population health, chronic care, integrated care, patient empowerment, and all that stuff. What do we mean by population health perspective, I think, on both sides of the Atlantic? It's a growing interest in the health and well-being of population and communities, not just in people who come to healthcare. It's a focus on individual and family care. It's a development of systems rather than siloed health service organizations. It includes proactive preventative care for healthy and chronically ill people. And it includes a focus on distribution of health within population. So it has the equity agenda also implicit in it, which I think is very powerful, because that's not around in many countries in Europe. Just because we have a universal health care does not mean you're being completely equitable on the population that needs you most. So, this is the stuff we stole from you. We stole risk stratification, Kaiser Permanente. We stole the chronic illness model. We stole, and we're stealing actively, the AAA. I encourage you to steal them as well. The idea being that that is what is going to take you, for us at least, it's what's taking us in this direction, in the transformative agenda. So I'm not going to explain them because they're full of power in many ways, and you'll see them. You can say, oh, this is theoretical blah blah or whatever, but actually, if you open the new legislation in Scotland, Denmark, some parts of Sweden, the Basque strategy on chronic care, some things going on in Central Europe, in Germany, and Netherlands, you'll see this stuff. So the question is, why don't you see it here everywhere? That's for you to answer. Some people are beginning, and this is Michael Porter's stuff from the business school in Harvard, basically says, he's basically repackaging this. He's basically taking the elements that are in here about integrated care, about identifying patient costs, and putting the efficiency agenda together with the population agenda and the health service agenda in a new framework. So basically, this is last month. Integrated, you see organized integrated practice units, expand excellent services across the geography once you pull it off, integrate care delivery across separate facilities, move to bundled payments, et cetera, et cetera. So basically, some people from the academic field and the business world are saying, so let me just repeat that, it's the business world that's saying it's going to be a good business if you move in this direction. They're not saying it's not going to be good business to be in this direction. They're saying if you move in this direction, you're going to change a lot of things, but it may be a good business model for the U.S. This is the triple aim. It basically tries to put together 3 things that together are separate. I don't know what happened here now. That wasn't the intention. Maybe that's what will end up happening with the triple aim. But those disciplines in those 3 circles, you guys doing medicine and some of us doing population health and some people doing per capita cost and efficiency stuff, the managers of the system, basically we're not under the same umbrella organization. And if we're not under the same umbrella organization, we're in separate buildings, we get financed separately, there's absolutely no reason to come together. So what's happening, and it's visible, and I think in a very interesting way in the Affordable Care Act, in some of the European frameworks, is that you're saying it's a long way away still, but if you start coming together, you're going to be able to get a much better health system going. This is the way the Commonwealth presents it. Well, what does that mean, let's say, more operationally, more specifically, to use these big frameworks and these big things? Well, it means, you see, to basically have a strategy, which is a community-based strategy to improving care of high-cost patients. So it's your high-cost patients, the ones, that 20% that's spending 80%, you start managing them in a special way, and you do things in your system so that at least that group starts getting better care. And it means a whole bunch of stuff on payment reforms. It means bundled payment, you see there. It means global payment arrangements. It means organizing the medical home, in Europe as well, wherever we don't have it. It means accountable care organizations. It means reinforcing primary care. In Europe, everybody says, oh, you have primary care, you're really lucky. You have primary care doctors, and it's true, we took a very good decision 25 years ago to do the specialty of primary care, and we have more primary care doctors. Well, wherever we have it, we're making more. We're doing more, because we still think it's not enough. And then the IT world, the technology world, of course, is going to help us move all this forward. So specifically, there's a whole bunch of tools that are going to help us take in this direction. And when I say we know how, is that there's a whole bunch of people, and that's not academic people, a whole bunch of people in many places in the US and many places in Europe who are knowing how to pull these levers in that direction. This is the way we did it. It keeps on happening. The triple aim keeps on getting bundled up there. This is what we did in the Basque country. I won't go there. We did some unapologetically top-down stuff. We said we need electronic medical records to connect primary care and hospitals. So that's going to happen in these next 3 or 4 years. We need to stratify risk, so we stratified risk. And most of us have health systems, health information systems, so that we can stratify risk. So all that information is just spread all over the place. And when you bring it together, and we introduce what we call joint commissioning or joint financing, which is your global payment. So from the top, you're sending signals, hey, down there, you better get integrated. And at the bottom, what we did is try to launch a lot of bottom-up innovation in order to get much more clinician. When I say clinician, I mean doctors, nurses, and all types of health professionals, to get people innovating in integrated care and finding how we have to link health and social care, patient empowerment, and what shape we would have to give to case nursing. But what we did basically is a mixture of top-down and bottom-up stuff. The underlying assumption, the signal that I just wanted to say is we have all these levers, we know how to move them. Some of them are top-down, some of them are bottom-up. But the important thing is that without some level of system orchestration from the top, I don't think it would have happened, or it wouldn't be beginning to happen in those 4 or 5 countries. So you need some top-down orchestration. But then that top, as we discussed today, has to be very generous with power and has to be letting the local people innovate in terms of the things that are up there. Now let me just very quickly, there's a lot of information of, okay, you say all this, but is it working? Well, Scotland. This is what, you have 7,500 less than the expected deaths when you do this stuff in Scotland. So I'm not only talking about the Basque country. In the Basque country, we're getting some very good results across several diseases. We're not there yet. We're still, of course, everybody's moving in this direction. It's very difficult. There are a whole bunch of antibodies from all types of people saying, I don't want to do this. Keep the system as it was. I was comfortable in the system as it was. And then those people, you just have to say to them, well, yeah, you're comfortable, the patients aren't. And if you're a chronic patient, only with one disease or with several, you're getting a really bad deal. So the health system is not about you. And that has to be said from the system. That has to be said, because you have to come back to the patient once and again. So anyways, let me just say then 3 or 4 things, and with that I finish off, in relation to then what type of, let's say, leadership should one be and then be? how does one unlock, how does one start, how does one continue that? You've seen this frog, you know, you've heard about the frog that doesn't jump off when the water heats up very slowly, and basically frogs die because the water has been going up to boiling point but very slowly. Somebody used the Cinderella analogy this morning, basically said Cinderella was having a really good time until 12 o'clock, but then 12 o'clock she had to go. So 12 o'clock has arrived, at least in Europe. I don't know if in the US it has arrived. 12 o'clock has arrived. The frog, the existing health system is the water's boiling, and we just have to move on to something else. And so what is interesting is that you can create the burning platform. In system transformation, you can actually encourage the burning platform. And you have to just, you know, show that one time and again that if we continue like we continue, we're going to end up in emergency care, and you know that, and I don't mean the patients, I mean the system, and you know what that's going to mean. It's going to be, obviously the solutions are going to be much worse than if we do it much more progressively. Christensen, again, and they're in Massachusetts, and these people, but basically they say, look, the delivery of care has been frozen in two business models, the general hospital and the physician practice, which were designed a century ago. Many of our predecessors in clinical care would actually recognize very much what we're doing today. The situation screams for business model innovation. Now let me go back. This isn't doctors saying this. This isn't health systems people saying this. This is the business people in some of your schools saying, let's get out of this. And then they say, well, it's only disruptive innovation that has the potential to make healthcare more affordable and accessible. So you have to be disruptive. And so I think the top policymakers, and I was given the opportunity that you just have to be damn disruptive, but in an organized way. So what does that mean? Well, John Copton in Northern Ireland puts it nice. I think he says, I'm going to be disruptive, but I think managed and transparent change is better than unplanned and disorganized change. So these things are very tough. It's very difficult to change where we need to go. But it can be partially planned. And we can be transparent about what we're doing. And we have to be open to saying to people, it's about time we do it. The other thing senior leadership is doing in many European countries is trying to get beyond this, their organization. I had an organization, 16, 20 hospitals, a whole bunch of health centers, everybody salaried, and everybody was running around, you know, the limbs were moving, but there was no head, there wasn't a vision, there wasn't a cohesive strategy to put it together. So you have everybody really busy, is what you call nicely busyness with a Y, and but there wasn't a vision of change. So the first thing senior leadership is putting, and I think that's what's happened here in terms of what has happened at the federal level, is that they've put a vision. You may not like it, and a lot of people didn't like the vision I put on. I've been talking for 4 years about chronic diseases, so they called me Chronic Man, and because it wasn't obsessed. It's just that's the agenda. So you provide. What's interesting, when you put a vision on the table, doctors, health professionals, nurses suddenly see, well, you may not like it, but this guy and this person is going in this direction. And at least he knows where he's going with the health system. And what's interesting is that, of course, it provides you a vision which is about the patient. It's not about cost containment. So you have to put, so Scotland, the vision in Scotland is about patient safety. That's about patients. Chronic care is about patients. Obamacare is about patients. You can get all distracted you want, especially this week with other stuff that is going on. But it's about coverage. And that is very, very important. The vision's there. So it's really up to a whole bunch of other people to engage now and to make that. The second thing is that you have to make it reachable. You can say we're going out to the moon, but in that strategy, in that vision, the targets have to be more or less reachable. You have to say, I'm going to manage better 5% of the 20% of the people that are spending 80% of the funds in the next 2 years. You make it reachable. You make it, you make it tangible for managers to move on. And then there's an expression in Latin America that I like. It says, well, love that doesn't make it to the budget is not true love. And the message is, of course, you have to put budget behind all of this stuff. From what I see, and the big change from the changes 15 years ago in the US, is now there's a budget behind this. I had to put a lot of budget behind this. I mean, you can't move all these levers and say, I'm going to do a new healthcare system without really transforming your budgetary process. And otherwise, it just stays as love. If you start putting the money, people say, well, looks like there's true love. Okay, last few comments. A lot of people try to do the same type of leadership in the low-hanging fruit, the tough management, cost containment, stuff that you do onto people in order to control cost. And they try to bring that leadership approach to the high-hanging fruit. And the high-hanging fruit is the transformative agenda. It's the how to get integrated care, how to do global payment systems, how to get patients empowered, how to do all that other stuff. You cannot be using that management approach with the transformative agenda. The transformative agenda needs a much more complex, and that's where we say you have to be much more generous with power. Over there, you don't have to be generous with power. I mean, if you're going to, like I did and like we did in Spain and many European countries, if you freeze salaries, you don't ask the physicians. If you want to do transformative stuff, you ask the physicians, the nurses, and the health professionals. You have to identify a leadership approach which engages health professionals. Now look at this. This is the Weston Dawson study, which is being repeated in different places. But this is within hospitals. I think it's very interesting. The more staff engagement you have as a manager of the system in a hospital or in a whole system, the better it goes across a whole bunch of indicators. The better your quality indicators are. The better your mortality rate is in that hospital. The more patient satisfaction outcomes you have. And what's interesting, the more efficient you are. If you think you can do a whole bunch of this stuff without doctor and nurse and health professional engagement, I personally think, of course, you can't. And what the evidence is saying is that you better do it in another way. That may take a bit longer. But since we have the tools, and if you add to those tools the right leadership approach, which engages health professionals, and health professionals engage with you at the system level, then you can go ahead. A lot of evidence coming out. I don't have time to support it. A lot of evidence saying this is just on one line of the evidence. Patient empowerment, you may have seen this. This is Oregon. This is your stuff. This is a way of measuring how engaged the patients are. So it's called PAM, Patient Activation Measurement. So yellow, you're a very engaged patient. You've been activated. They've been training you to self-manage. And in level 1, you're expected to continue to be a passive patient. Up here, you're an active patient. Over there, you're a passive patient. This can be trained. This can be developed. This can be taught. Okay. Now, look across these diseases, medical adherence, the evidence saying if you have patient activated, better diabetes control, better adherence to the medication, heart disease, hypertension. Across all the diseases, better, better, better. Back to doctors. Patients who get more support for self-management from their doctors are more activated than the ones where the doctors don't even talk about this. Now, this is just one piece of evidence. That article ends up saying these patients in yellow are between 8 and 21% cheaper because they're activated. They're not coming back to you all the time. That may not be very good for billing sometimes, but they're not coming back all the time. And then, therefore, just to package it, huge challenges, a very important burning platform. The burning platform's on your side at a system level. You need to use it as an opportunity to change. There are new frameworks. The new frameworks are yours, I told you. They're not European. I haven't found European frameworks. The new leadership approaches where more engagement are paying off. In those organizations where you engage health professionals, it pays off. There's very interesting across-Atlantic new legislative and policy environment to help all of us move forward. There's growing evidence, as I've just shown, just with one. And it's not only about health outcomes, it's also about it being efficient. There are more and more countries doing it, and I think it's inevitable. So if it's inevitable, it's probably not a good idea to wait. Okay, thank you.
Your healthcare cost pyramid actually, I thought, resembled very interestingly the wealth distribution in the United States, with the top 1% having maybe 40% of the wealth and the bottom 50% having 3% or something like that. But this role of physicians in this transformational strategy, I have wondered whether we have to be the prime movers and say what is treatable and how do we treat the treatable things in the cheapest possible way. Is that
I think so.
an approach?
I think so. I think the medical associations of the different specialties should be saying to the policymakers, this is where we have waste. We shouldn't be doing these 10 things. But we think we shouldn't be doing these 10 things. So don't pay them. The second thing is really invest in this other stuff. And that should also be coming, I think, from health and clinical associations of all types. Is that process up and running in Europe? No. So it's the governments who are beginning to say, this is in, this is out, etc. And it's much better if it happens from physicians. The other idea behind your comment that I would say is I think physicians have to be engaged because patients believe their physicians, they don't believe policymakers. I had much more credibility when I was a doctor than when I was a policymaker. So don't become policymakers.
Thank you very much for the talk. Much of healthcare outcome is less to do with health systems and more to do with
we're failing there. Let me say the best way of explaining this is when you're sitting with your fellow ministers around the table, and you go with them with the WHO concept of health in all policies. Well, the housing minister doesn't give a damn. He has his agenda. He's doing his thing, and he's not there ready to listen to you to say there are health consequences in your housing policy or your educational policy. Where it seems to be working in part is, I think, health and education and schools are getting their act together a bit better. But I think I have no lessons, Europe has no lessons to give anybody on that because, for example, let me tell you, in Spain, it's still much more expensive. It's still much more expensive to buy skim milk than a chocolate bar. And so until you actually have economic policies, agricultural policies, which change all that, I don't think it's fair to ask the population, hey, change behavior all the time. I think the people who have to change behavior are the policymakers. They have to make sure those things, like the example I just said, ensure an economic logic where it is easier, of course, to buy healthy food, to have healthy environments, versus, but that in the reality of policy making does not happen within government. It doesn't happen, at least that I know of, almost anywhere. It's a sad answer I gave you.
Ironically, in our country, organized medicine, the medical system, politicians who promise to help reduce the risk of medical malpractice suits. These are the same politicians that are trying to destroy healthcare reform. Do you have similar problems in Europe?
No, we don't, because we don't have a fee-for-service arrangement that has encouraged a lot of that. Switzerland has, and actually Switzerland has a bit more litigation than the rest of Europe. It's not only fee-for-service that is behind that, but it is a big element. Let's say it another way. That market is not at work in Europe. You get moral, from some sort of clinical error or whatever, you get moral pay in Europe, but you don't get big money. And if you don't get big money, you don't have lawyers waiting outside our hospitals. Is that the answer to it? Yeah. Russell?
Just a comment and then a question. The comment, earlier question, about the social determinants and how policy aligns. Always found an interesting lesson looking at heart disease prevention compared to U.S. trials in the U.S. that did pretty much a lot of the same things, except for the question I have is about the patient empowerment. You added a number of things, or Judy Gribbett's patient. Many of us, would endorse and think that's key. Similar to the way examples you've given about, sometimes the talk going, but there's no money there or love behind it. I'd say that's kind of the situation that I see. I think that's a huge culture challenge, actually, for healthcare. A lot of people want to do it or say they're doing it, but sure what's really happening. It's not. I'm just wondering if you have any lessons learned to share about how to implement that so that real patient empowerment happens.
Well, to the first part, and I think North Korea was a fantastic example on CVD, but they started with really, really bad CVD. I mean, everybody was dropping dead there because of the way the Finns in the 70s were eating. So it came down, then, how do you continue after? The second, also to continue on that one, because the question that was posed about health determinants, I sort of like, it's still theory, but I sort of like the idea behind ACOs and what we call microsystems, ecosystems, or local systems, because at the community level, if those organizations start doing it, maybe at the community level you can have some work around vulnerabilities and upstream stuff. It won't be policy stuff, but in a community maybe there's some level of intervention that can be done. In relation to lessons about how to move forward, when we decided to engage on all the things that I did top-down, bottom-up, all of them had partial evidence of movement. And at the policy level, you have to decide whether that's enough or you want to wait another 10 years, people getting bad deal outside, and wait another 10 years until you have the complete evidence to move forward. And the way to move forward is to actually start doing something. So on 3,000 patients, 4,000 patients, 5,000 patients, we did in the Basque region self-management. And then if you have some early results, that will push another 10, et cetera, et cetera. So it has, the decision is disruptive, but the process is quite incremental. No, I think the things we're talking about are need adaptation, obviously in the rural world, versus what seems to be happening, at least in Europe, is, and to my taste a bit too much, is people are trying to resolve the rural situation through technology only and not through organizational development and through infrastructure as well. And I don't think the home care tech is part, I think it's a key part of the solution to control, I don't know, COPD at a distance or diabetes at a distance. But then you have to have somebody to go. Sometimes you have to have somebody to go. Somebody, you know, some people say, I'm on the love scene this time. People want a face. People are going to want a face around the care agenda. It's not only going to be around technology, although technology is going to be a key enabler. So to your question about what's happened, the big difference is that people, I think, are a bit artificially resolving the rural distance logic in some parts of Europe. Countries like, you know, Finland, which has, you know, 3 people up in the north. Through technology, I think you're going to need to invest in certain infrastructure anyways. And of course, it should be primary care infrastructure. Don't build a hospital. Yeah? Well, we talked a lot about that in the last 2 days, and there's some people in Massachusetts, as an example, I know somebody in London is on to that, teaching doctors on their first year, first month. And this person in Massachusetts starts the class saying, I've convinced the medical faculty for you to be here 2 or 3 hours with me at the beginning of your career before you get wasted. And I was there, and I think what came out very clearly for me is that it's not going to be people from the business sector who come in into health and try to compensate for what happens to us during 6 or more years in medical training through 3. It has to be within the culture and the strategies of the medical schools themselves and nursing schools, not to waste people. I think we do get wasted, and that he's right. But the process has to come from within, because the students look at their medical teachers. They don't understand why a person from the business community is coming then to tell them that. So that's just an example of people trying to do things because they're tired of waiting for the medical schools to change their curriculum and to introduce some of these things in the discussion. I think all this has to be happening, I don't know how, but it has to be happening during all 6 years of medical training. All this stuff has to be floating in different moments. Students have to be able to come out with a much more sophisticated thinking about the economics, about the quality agenda, about patient engagement agenda than they are now, everywhere. And I know the Finns were doing something interesting in changing curriculum, but I don't think anybody has cracked it. Good. That's it. Frank?
Thank you.
Oh, one more.
If we consider the senior leadership to be for state rather than federal, are we kind of shooting ourselves in the foot? Washington, D.C. to drive.
Well, I think the Washingtons of the world have to create a legislative environment so that the states can do what they do. But the states have to do also then pick up the challenge. And I think what's happening in Europe, Canton in Switzerland, the Basque Country in Spain, Scotland in United Kingdom, in New Zealand, it's one of the regions. It's happening from the state region perspective. That's where there's a scale in which you can manage all this around 3.5, 4, 5 million people. That's manageable. 300 million or 50 million Spaniards is less manageable. But it does not mean the national role, the national level, the federal level, and all our more decentralized country. Obviously, for me, here, what has happened is the right thing. And I know it's very difficult, but at the top level, there is a true policy role, and they have to continue. And what they've done, at least from my perspective, is, and that's what's different from 17 years ago, it's true love. There's money on the budget.